Do mechanical characteristics define who responds to spinal manipulative therapy? How do you know if someone will respond to care? Intuition? Based on the literature evidence indicating a relationship to psychosocial predictors like depression? Or perhaps based on a clinical prediction guide or rule using history and exam indicators, or response to the first treatment? Or more likely a combination of these with an emphasis on intuition? What if it was possible to actually predict response to care based on objective measurements of biomechanical phenomena? In other words, something you might be able to measure in practice. This holy grail has been sought after for decades. However, until recently, little has emerged and has essentially remained unnoticeable as basic science preliminary research. But a new publication should change that. It's entitled, "Do Patients with Low Back Pain Who Respond to Spinal Manipulative Therapy Differ Biomechanically from Non-Responders, Untreated Controls, or Asymptomatic Controls?" published in Spine in 2015. Based on past theories and studies, the researchers wanted to see if there were biomechanical measurable indicators that might independently or as a group predict response to care. So although the three biomechanical features measured are not necessarily intuitive for most clinicians, they were selected based on past literature evidence that may have gone unnoticed by many, much of it by the researchers of this current study. The three biomechanical measures utilized by the researchers were spinal stiffness, multifidus muscle contraction, and disc diffusion. These were measured pre- and post-manipulation to determine effect. So what should happen to each of these measures in relationship to improvement in spinal pain? Past studies indicate a correlation between a decrease in spinal stiffness, an increase in multifidus muscle thickness ratio, and an increase in disc diffusion post-manipulation in those who responded to manipulation. So how are these defined, and more importantly, how do you measure each of these? Well, let's start with muscle stiffness. The researchers used an instrument that is a motorized indenter that controls the loading velocity and measures force and displacement. It's controlled by software developed by National Instruments of Austin, Texas. Measures are averaged over 3 indentations taken pre- and post-manipulation using a 5 Newton preload and a maximum load of 60 Newtons at the L3 spinous process level during held exhalation. Prior studies, one by the same researchers, indicated that this may be a valuable post-treatment measure of responsiveness to manipulation. Next, muscle contraction. The lumbar multifidus is used as the indicator muscle. Using ultrasonography, the lumbar multifidus thickness ratio is measured using thickness at rest and with contraction. In this study, this was accomplished by having the patient raise a weight to touch a bar 5 centimeters high with the contralateral hand, producing a 30% maximal voluntary contraction. Specifically, the thickness ratio was calculated as thickness contracted minus thickness at rest divided by thickness at rest times 100% using the distance between the posterior-most tip of the target facet joint and the thoracolumbar fascia. The L3 facet joint was located using ultrasound. As it is utilized in this study, the post-manipulation measure of thickness is a correlate to activity of the muscle, so this is not necessarily a measure of atrophy as one might expect from the measure of thickness ratio. Again, quite a few past studies have indicated that there is a relationship between the multifidus muscle and low back pain. They also indicate high reliability, which can be a concern with the use of ultrasonography. Specifically, Fritz and co-workers found that the status of patients using a clinical prediction rule they developed might be correlated to low back pain disability through its relation to lumbar multifidus contraction thickness. We'll review that CPR in a moment. Also, post-spinal manipulative therapy improvement on a modified Oswestry Disability Index score for more than 1 week was associated with immediate decrease in the spinal stiffness at L3 and an immediate increase in the lumbar multifidus contraction thickness at L4 and L5 during contralateral arm lifting. And finally, disc diffusion. A specific type of MR imaging referred to as DWI or diffusion-weighted imaging was used. Sagittal images were acquired. They then used the ADC or apparent diffusion coefficient. This is a specific calculation that's been reliably used as a proxy measure for disc diffusion. The higher the ADC values, the more diffusion in the IVD. In this 2014 study published in the Journal of Orthopedic and Sports Physical Therapy, researchers found a relationship to pain intensity decreases following manipulation and an increase in disc diffusion. Here we can see this type of imaging compared to standard MRI. Again, this is referred to as diffusion-weighted imaging, or DWI. Now to the study. Let's look at how patients were selected and assigned. In a past clinical prediction rule or guide by Fritz et al., it was found that patients who had 4 or 5 of these indicators reported clinically significant improvement on the Modified Oswestry Disability Index. These included duration of current episode of symptoms less than 16 days, location of symptoms not extending distal to the knee, scores on the Fear Avoidance Behavior Questionnaire of less than 19 points, at least 1 lumbar spine segment judged to be hypomobile, and at least 1 hip with more than 35 degrees of medial rotation range of motion. Patients ages 18 to 60 years with or without low back pain were recruited. Those without low back pain were used as an asymptomatic control group. Inclusion criteria were low back pain with or without leg symptoms, low back pain intensity of at least 2 on the 11-point numeric pain rating scale, and a Modified Oswestry Disability Index score of at least 20%. Exclusion criteria were signs of nerve root compression, scoliosis, osteoporosis, joint hypermobility syndrome, previous lumbosacral surgery, or any spinal manipulative therapy or stabilization exercise treatment in the last 4 weeks. Individuals with low back pain were enrolled into either the treatment group or the untreated control group. If they possessed either 4 or more of the CPR characteristics, they were categorized as predicted responders. If they had 2 or less characteristics, they were categorized as non-responders, and those with 3 were excluded. Manipulation consisted of a posterior-inferior thrust to the patient's pelvis. As you can see, this is not a standard chiropractic adjustment, but a PT version of side posture. The supine participant crossed and put his or her fingers behind the neck. The clinician stood opposite the side to be manipulated, rotated the trunk in the opposite direction, and then delivered a high-velocity, low-amplitude thrust to the pelvis in a posterior-inferior direction. This was the manipulation utilized in prior studies by Fritz et al., who developed the previously mentioned clinical prediction rule. It's important to note that the clinician, in this case a physical therapist, delivered spinal manipulative therapy to both sides in each session, and that a second SMT was allowed for each side if the first SMT did not cause a cavitation. In this study, individuals in the manipulated group were categorized as responders or non-responders based on a self-reported disability on day 7 using the Modified Oswestry Disability Index. At baseline, there were no significant differences in spinal stiffness or the lumbar multifidus thickness ratio among the asymptomatic or non-manipulated group or the responder and non-responder groups, and no significant differences in baseline lumbar intervertebral disc diffusion among patient groups with low back pain who were not manipulated and those who were either responders and non-responders. The results? After spinal manipulative therapy application on session 1, there were decreases in spinal stiffness for participants with low back pain that were significantly associated with an increased lumbar multifidus thickness ratio at all measured levels, as well as increases in the ADC values in the discs of L3, L4, and L4, L5, meaning increased disc diffusion at those levels. So from this study, it appears there is a relationship between response to manipulation and biomechanical changes reflected in spinal stiffness decreases, increases in multifidus muscle contraction, and increases in disc diffusion. So, do we simply use these results to state that there is now literature evidence that there are biomechanical effects of manipulation that contribute to responsiveness, or do researchers go the extra uncomfortable step and attempt to see if these can be used as predictors of response in our low back pain patient populations? The question then is, how practical are these biomechanical measures in clinical practice? Given only one of the three measures, spinal stiffness measurement, is a potential tool in clinical practice, is that sufficient enough for prediction, or do patients need a referral to a center that has both ultrasonography and MRI? Do centers for the measurement of these indicators develop as a response to future studies that corroborate these findings? Or are there clinical surrogates for these measures, meaning are there history or physical exam findings that match to the mechanical indicators closely enough that they can be used as a proxy measure? We do know a little in this regard from previous studies. For example, we do know in this past study published in JMPT that there does not seem to be an apparent relationship to tender segments on palpation when compared to spinal stiffness measures. But with Fritz et al., in the study that evaluated and developed the CPR, one of the characteristics was the determination of segmental hypomobility, a clinical indicator used by most clinicians. Many questions left unanswered. For example, if you noticed, the participants were classified as responders and non-responders based on the Fritz et al. CPR prior to looking at results. They were fairly equally divided in the manipulated groups. What we don't know is, are the CPR-designated responders those that responded to manipulation in this study? In other words, did the CPR work as an identifier of those that had response to care and therefore the observed changes in biomechanical outcomes? This is not clearly reported in this study. Also, does standard chiropractic manipulation have the same effect as this PT-derived manipulation? And how accurate and clinically relevant are the measures used, given the comparisons are done using mathematical abstractions, such as percentage of change, ratios, etc.? In any case, this study should be viewed as a seminal groundbreaking study that launches hopefully significantly larger follow-up studies that eventually drive clinician behavior and benefit our patients.